survival rate 5 years after the initiation of renal replacement therapy. In 76% of the cases, as compared with 92% among children with ESRD, that means end-stage renal disease. Primary hyperoxaluria type 1 is the most devastating subtype, particularly when it occurs in infancy. But patients who have the GLI 170 ARG or PHE 152 allele mutation have a better overall outcome than other patients with type 1 disease, partly because of their sensitivity to pyroxene. Patients with primary hyperoxaluria type 2 appear to have a less severe course, although the two disorders cannot be distinguished according to the age at onset, and in some instances, primary hyperoxaluria type 2 is initially assumed to be type 1, and primary hyperoxaluria type 3 has also been severe course and may be silent or limited at stone formation. Diagnosis would depend on the clinical presentation, but the most important part of the diagnosis lies in the fact that must be detected. Primary hyperoxaluria, the concerned clinician must think of this condition even in asymptomatic state, when somebody is coming with features of calcium or oxalate deposition anywhere in any system. What is needed is a consciousness. Well, this is impossible. Otherwise, if we think of other conditions, the patient will be detected when there is total renal deterioration and eventually transplant. And with transplant, life is starting. Considering the possibility of primary hyperoxaluria and pursuing evaluation that in accordance with the published results that may facilitate earlier recognition of the disease. Because the majority of the patients with primary hyperoxaluria present with symptoms related to urolithiasis, assessment of the risk of kidney stone based on measurement of urinary level of oxalate, calcium, citrate, sodium, magnesium, and urate, as well as urinary pH and volume. It is central to a good evaluation. In patients with primary hyperoxaluria, kidney stones usually consist of more than 95% calcium oxalate stone, and they are monohydrate, and then the usual pale color and non-homogeneous in appearance. You see unaffected person's liver. Here you can find chronic kidney disease. In the first part of the chronic kidney disease, there will be slight increase in length, breadth, and later on the progressive shrinkage. If you see the functional study of the chronic kidney, stones have already started appearing. Oxalate blisters could be traced in tubes. Chronic kidney disease is progressing and size of the stone is increasing. It is the end stage chronic renal failure with involvement of the liver and primary as well as reactive involvement of the entire kidney. Kidney is studded with calcinosis. Why so late? Because we are not mentally prepared to accept this condition early. The excretion of urinary oxalate is variable. In the first year of life, the range of metabolites in patients with primary hyperoxaluria, but a persistent elevated excretion or a urinary oxalate creatinine ratio greater than reference range for that age group can guide us about the possible primary or, in the absence of a secondary hyperoxaluria, which needs further evaluation. As it is a genetic disorder, a family history of primary hyperoxaluria, particularly type 1, a genetic screening can be performed, and testing during the first trimester of pregnancy can establish a prenatal diagnosis. answer is, if you want to solve the problem, early detection, a conscious clinician, if you can't solve the problem and extend misery in the life of the couple or the mother who is harboring this baby in the first trimester, best thing is go for selective sampling of the chorionic villi and eventually confirm the diagnosis. You can also do selective amniocentesis and confirm the diagnosis of primary hyperoxaluria. If that is so, you can have a consent and go for termination. Till we are in a position as to tackle this phenomenon, early detection should be given a priority. We feel terribly sorry for this helpless mother coming from one part of the world going to different parts of the world. I could understand, I could feel her heart. She wants that all doctors must be conscious, clinicians must be conscious and try to detect the disease a little bit early. The question is, even if you detect this case earlier, is it possible to extend the life up to normal term? Answer is no. But mother will be happy if it extends for a second event. Consciousness is the most important. Once you are conscious, there is a family history of primary hyperoxaluria, you go for genetic screening. For that, when the baby is within the first 3 months, you go for chorionic villi sampling or amniocentesis, eventually detect the case. Now, on the management will depend on the stage of presentation. If it is early, lifestyle modifications can be done. There should be clinical supportive measures. Once the diagnosis of primary hyperoxaluria is being considered, supporting measures should be initiated. If you do not take adequate steps or supportive measures, it will lead to a case of chronic end-stage renal disease. Fluid intake should be restricted to 2 to 3 liters per square meter in the body surface area. But infants with tube or gastrostomy, feeding would be done as per requirement. Oral potassium citrate is used to alkalize the urine so that the pH is low, and pH is around 6.2 to 6.8, and this may inhibit crystallization or deposit of oxaluric crystals, calcium oxalate crystals in the tubule and secondary blocking the tubules. One thing, you have detected a case of primary oxaluria on the basis of calcinosis, and you wanted that this should be removed because of the primary impact, the secondary impact, tertiary impact. Primary impact is physical obstruction. Secondary impact is inflammatory changes. Tertiary impact is secondary inflammatory changes as sympathetic other inflammatory changes are on the we cannot, obviously the patient might even say, best option is to do the surgery without doing the surgery itself. Remove the stone without cutting the baby. That can be achieved with extracorporeal short-wave lithotripsy. With lithotripsy procedure, you don't have to cut this. But with lithotripsy procedure, there are other side effects. Please remember that lithotripsy is not advised in case of primary hyperoxaluria because of calcium oxalate stones do not easily fragment, and because the risk of parenchymal damage is secondary to lithotripsy. This is basic. You have detected a case of primary hyperoxaluria. Obviously, detection is mostly late. Standard treatment for other conditions apart from this would be lithotripsy. You don't have to cut anywhere in the kidney or cut the skin. With lithotripsy, shock or shock pain, it will disintegrate the stone. But this will not be allowed in case of primary hyperoxaluria. Not only that can cause deterioration of the kidney function, but most of these stones will not disintegrate. This is very important and everybody must remember this. When this primary oxaluria with physical obstructions of the tubule, secondary inflammatory changes and progressive renal damage leads to a condition of chronic renal disease, ultimately there is no other option but to go for dialysis. Conventional hemodialysis. This is the condition. We can see when we will be going for hemodialysis. It will be down 2 to 3 hours, right? Now, this is a condition when both hemodialysis and peritoneal dialysis may be done simultaneously. The idea is not to eliminate sufficient of oxalate to avoid a continuous positive balance. The intensive strategy must be to clear plasma oxalate, not the deposited oxalate crystal, and limit systemic involvement. The preemptive transplantation is not feasible. Therapeutic strategies that include short daily session of high flux dialysis, nocturnal dialysis, or a combination of both hemodialysis and nocturnal peritoneal dialysis, and needed to pre-dialysis level of plasma oxalate below 30 to 45. 30 to 45 or below. Since liver is the sole organ for glyoxylate detoxification, excessive production of oxalate will continue as long as native liver is present in patients with primary hyperoxaluria type 1. Naturally, if we say we were doing preventive transplantation, preventive liver transplantation. In this condition, those who are interested in preventive liver transplantation, my advice is, do you know cost of liver transplantation? Do you know complications of liver transplantation? And what is the maximum life available? Discussing something in theoretical perspective only is not everything. Theoretically, as liver is the primary site for involvement, we can say preventive liver transplantation. But if you see the global statistics, in case of liver transplantation from India, the life is about 9 months to 16 months. Out of 9 months, 6 months in the hospital. And the cost is around 45 lakhs in corporate hospital for the procedure only. Primary procedure cost 45 lakhs. Then you are doing liver transplantation with 5 months in the hospital and spending around 75 lakhs, and you find the life has become extended from 9 months, out of which 5 months in the hospital, to 12 months. The question is it worthwhile? In centers of excellence in the United States, that is 3.5 to 4.2. Then you have to go for retransplantation. That is primary liver transplantation. Patient, it's about 4.2 years patient live. Eventually, there is secondary liver transplantation. Here the life will be definitely curtailed further because of continuous use of immunosuppressive and other supportive factors might be responsible for deterioration of type of life, including its quality. What can be done? You have detected, exceptional case, you have detected the case early. You have opted for early liver transplantation. Or say in case of advanced condition, you go for early liver transplantation along with renal transplantation. Once again cost, say about 1 crore, life expected, say about 9 months, United States, 5 crores, life expected is about 3 years. Somebody is detected to have this disease at the age of 5. You do the surgery, you do prophylactic liver transplantation and renal transplantation, all prophylactic, start something else. crores of rupees, or in terms of dollar, million US dollar. The life is, 3 years, of which 2 years in the hospital. But what are the options? In terms of rationality, I will suggest option is early detection. Till gene therapy is formalized, till the mortality and morbidity of gene therapy has been reduced drastically with more and more understanding of the therapeutic purpose. If that is achieved, I think it is achievable. Then we can go for gene therapy, or otherwise we have to depend on transplantation procedure. But the problem is transplantation is money, infrastructure development, as well as life, the quality of life. Questions are basically ethical. Ethics. Is it worthwhile for this poor little boy or girl, 5 years old or 8 years old, who has been detected late? You have one for kidney transplant, liver transplant. For the surgeon, for the transplant team, they say, well, the global survival is 12 months and this patient survived for 13 months, 2 days. But the patient was unconscious for 3 months. Patient was under the respiratory support for 2 months. What can we do? I think my approach is early detection is the best thing. When the patient presents with this hyperoxaluria, early detection, early treatment, so that pre-dialysis life could be extended. Instead of developing chronic renal failure, in 3 months undetected, it could be extended to 5 years. That means equivalent to a first transplantation procedure. Lifestyle modification. And in the same family, when there is primary hyperoxaluria, we'll have to go for next baby, go for